So a fair bit of what I'm going to say has already been covered, so I'm not going to dwell on that, and I'll try and concentrate more on the bits that haven't been covered. First of all, the reason that we started a private psychology practice specialising in cancer-related distress is because this area isn't well resourced at all. We've got one psychologist 1 day a week at Flinders Medical Centre in this building to service all cancer patients, which frankly is a joke. And so Lisa, who's that psychologist, Lisa Beattie, and I set up the private practice, and we're located on the 5th floor of Flinders Private. And so our contact details are in the folder that you've got on our handout, so if you do want to refer, you can find us there. Okay, what do I click? That one? There we go. Okay. So, as has been quoted already today, the prevalence of sexuality and intimacy issues is high. It ranges between 40 and 100% of post-cancer patients, and it varies by gender and it varies by cancer type, but it's not specific to the sexual organ cancers. So even people who've got pancreatic cancer, lung cancer, head and neck cancer, almost all of them will report some sexuality and intimacy issues. But what's interesting is they'll report it when they're asked. A very, very small subset of those patients will actually seek out help for sexuality and intimacy issues. And the reason for that is that the big barrier, as has been highlighted, is embarrassment. We're socialised in Western culture not to talk about sex. You know, when you go to a dinner party, you don't talk about politics, religion, money and sex, yeah? If you talk about sex, you talk about it at home in the privacy of your intimate family setting. So it's no wonder that people don't seek out people to talk about this stuff. I've broken it down by gender, and this has been gone over already today. So males commonly report reduced orgasmic sensation, decreased erectile rigidity, absence of orgasm, impairment in sexual desire and arousal, and decreased sexual activity and satisfaction. And women report body image issues, feeling a lack of perceived attractiveness, decreased sexual activity and satisfaction, and lubrication and sexual response problems. So you can see there that common to both sexes is that decreased frequency and satisfaction, but it doesn't happen in a vacuum. So this slide shows that there are a number of factors that we see as connected to people's sexuality and intimacy issues. And I'll go round the clock, starting at function issues. So there's some of the things that have been talked about in detail today, about changes in sensation, about changes in function. Then there are things like body image concerns, and what we often find with women is that body image concerns are often preceded by a history that often starts in adolescence, and when they get a cancer diagnosis, it lights a fire under that. Body image concerns often relate to things connected to loss of tissue, so loss of breast tissue, can relate to scars, it can relate to hair loss. And body image issues aren't specific to women. We see men experiencing the same thing. Interestingly, they'll talk about the loss of hair not on their head. They're okay with that because that often signifies kind of masculinity, but they'll talk about loss of facial hair as being something that really bothers them. And all of those things feed into their perceptions of themselves as attractive sexual beings. Practical changes. This isn't talked about much at all. It's talked about in passing, and it's not usually recognised as a problem. People stop sleeping in the same bed, and they stop sleeping in the same bedroom when they're undergoing cancer treatment. Sometimes it's out of concern for themselves, so the cancer patient is struggling with the consequences of cancer treatment. They're up in the night, they've got pain, they don't sleep a lot, they're restless, they're unhappy. Sometimes it's out of concern for their partner. So they say, I don't want to keep you up, I don't want to disturb your sleep, you're the one having to care for the rest of the family, I'm sleeping all day. So they split bedrooms. And what starts out as something that's kind of benign and full of good intent can have a whole range of unintended consequences. Then we go on to stressors related to ill health. We know that cancer makes you poor. Often people who are going through cancer treatment are forced into early retirement, or they have extended leave. It means that their ability to earn and provide for their family changes, and that dovetails nicely into issues about self-efficacy, about identity, about their role in their family and in their community. It's particularly bad for men. The other thing is that, I'll just move on to treatment effects. We've talked a lot about that today. It doesn't take a rocket scientist to understand that if you've got pain, nausea, things like having a stoma bag, none of those things are conducive to a good, healthy sex life. And then we've got role changes. That was touched on earlier, I think, by Linda, about when you've got an intimate relationship and then someone's diagnosed with cancer, the intimate partner relationship changes into partly an intimate partner relationship and a lot of carer-patient relationship. What we see in therapy often is that people slip into these dual roles, but they don't recognise it. Nobody's talked about it. Nobody's explicitly said, hey, could you be my carer? That hasn't happened. And so they don't recognise that they're switching in and out of these different roles, and sometimes raising their awareness about that and letting them understand that there are times to be intimate partner and there are times to be carer-patient helps them adjust. The other thing about being a carer, and this was touched on earlier also, is that when you're performing very personal care tasks around things like toileting, changing dressings, dealing with the most intimate and personal things, there are dignity issues there, and that makes it really hard for the patient and for the carer to let go of some of those, what can be mental images. They can be sensory, things like smell and touch and pain, and those two people have been involved in those things, and that gets right in the way of getting intimate. Okay, this is the real deal psychology stuff. Cognitions. So the sort of thoughts that we see people who are struggling with sexuality and intimacy issues are things like, I'm not desirable anymore. What if I can't satisfy my partner? I'm not a man anymore. I'm not feminine anymore. What if it doesn't work? What if it hurts? I'm a freak. What if they reject me? So you can see that the sort of thoughts that they commonly have kind of fall into two camps. They're either fears or they're beliefs, and mostly they're maladaptive. They're accompanied by negative emotions. So sadness and loss around not being able to do the sorts of sexual activities and have the sort of intimate relationship that they used to have. Fear about not being able to perform the way that they used to. Guilt about not being able to satisfy their partner, and anger about having something so important taken away from them outside their control and not of their choice. The behaviour of choice for this is avoidance. We see it almost exclusively in this area. Humans are preconditioned to do more of what makes them feel comfortable and less of what makes them feel uncomfortable. So they innately feel uncomfortable, they just steer clear of it. Like I said, it might start out as a preference or in relation to treatment effects, and it becomes a pattern, and the longer it goes on, the wider the gap becomes and the harder it is to change. What starts off as fairly benign, as I said, has unintended negative consequences. Avoidance works beautifully to reinforce maladaptive fears and beliefs, and it prevents people from having the opportunity to have a positive sexual or intimate experience which challenges those negative thoughts. So the effect on the patient and on their partner is that their maladaptive beliefs and fears become reinforced, the partner can feel rejected, and that can damage relationships. So how do we know if there's a problem? If avoidance is their strategy of choice, are they going to say anything? And I think what we've established is often that they won't. But as Paige highlighted, if you start the conversation, you've got some chance of finding out if there's an issue. There may be an opportunity when you're having a conversation in a broader context to ask them gently about how their sex life is, about how they're feeling about themselves, and then you can run with it from there. The other thing to remember is that this is having an effect not just on the cancer patient, but on their partner. And often I find it's the partner who raises this as an issue. So it's important to not just check in with the patient. If you've got the opportunity, check in with the partner too. Okay, what can we do about it? As I mentioned before, we're socialised not to talk about sex, and that applies equally, as Paige mentioned, it applies equally to clinicians as it does to patients. So one thing to do about this is to practice talking about sex. Practice talking about it with your partner, practice talking about it with your colleagues and peers, and develop a good game face. It's important that your clients feel comfortable enough about talking about this sort of thing. If you look shocked, they'll stop talking about it. I use humour and I use self-disclosure. There's variation in psychology about how much self-disclosure, if any, is appropriate. A little bit goes a long way. If people feel like you can say, yeah, I've used KY jelly and it helps, they'll get on board. If you're talking about it like it's something foreign to you, they're much less likely to feel comfortable about it. Validating and normalising. So bottom two on the rung there, we can all do validating and normalising. So validating is listening. It's acknowledging that this might be A, hard to talk about, and B, hard to experience. Letting people just get this out can be really significant for them. They might never have talked about this to anyone else ever. Normalising it means placing it in the context of other people's experience. So talking about the fact that you talk about this with all your patients and letting them know that it's a very common thing to struggle with this. Just starting to understand that they're not the only people who are having this experience can be really significant. Education. There's a significant positive value in correcting misinformation. A lot of misinterpretations and assumptions are based on inaccurate information. So you as clinicians have more of the accurate information, share it with them. Some patients seek to educate themselves using the internet. I'm sure you're all familiar with the perils of Dr. Google. My experience is we can't stop Dr. Google, but we can provide some helpful guidelines. I say to my clients, if you're going to go on Google, I want you to limit your searches to Australian health government websites. That way it's relevant, up-to-date, peer-reviewed information. The last two, which are behavioural and cognitive interventions, are what we typically do in therapy. And just because we do them in therapy doesn't mean that the ideas in principle can't be taken on by other people. So behavioural interventions are really about giving people the opportunity to learn that maybe their fears and beliefs are in fact incorrect. And the idea with behavioural interventions is that you give them little experiments to try and you set them at a low level, so you set them up for success. So typically in this group, if we've got a couple who have stopped having any sort of intimate relationship, you start really small. You reintroduce things like sleeping together in the same bed, doesn't matter if they're wearing pyjamas or not, but you get them to go to bed at the same time and you get them to touch hands and touch feet at night and in the morning. So you just start reintroducing touch. You get them to sit on the sofa at night together for 15 minutes a night and watch TV and hold hands. Very simple, very small, but it's just reintroducing intimacy into their relationship. If you suggest that they hop straight back into the sack and get going, that's called flooding and it won't work. Then we move on to things like cognitive interventions, and this is really around challenging some of those maladaptive thoughts. It's about working with their expectations of themselves and their partner, about sex itself and about whether they are desirable to the other person. Just because sex is different after cancer treatment doesn't mean it has to be categorised as better or worse. It can just be categorised as different. And sometimes that's a big thing to get your head around if you've had a 40-year marriage and you've always done it the same way. Recalibrating beliefs around what constitutes masculinity and femininity. So we get socialised again to some very rigid ideas around what constitutes being a woman and being a man. Challenging that sort of stuff, doing exercises around close your eyes, tell me if you know whether a man or a woman's walked into the room, and you learn that actually it's not just about boobs and testicles, it's actually about a whole lot of other things. Highlighting the link between uncertainty and anxiety, so around performance anxiety, and giving them some strategies to work on that is also something that we do in the sense of cognitive interventions. So that gives you a flavour of the type of work that we do when we get to therapy, but there's a whole lot of things that you guys can do before it has to get to that point. Finally, and importantly, there's a bunch of research that's shown that interventions in this area are much more effective if they are done with a couple rather than individually. So wherever possible, if you're talking about this sort of stuff, if you can be talking about it with both partners in the couple, you're going to get a better result than with one. Because if they're practicing avoidance and they're only going through it with you, they're going to go home and not talk about it at home either. Whereas if you break through the barrier with the two of them, you've got a possibility that you'll launch something that they can carry on with outside of your room, your session. I hope that's been of some value, and I'm happy to take questions now or later.